Hi, this is Dr. Pedro Ramirez, editor-in-chief of the International Journal of Gynecological Cancer. And today I have the great pleasure of having on the podcast Dr. Félix Boria from the Hospital Universitario Nuestra Señora de la Candelaria in Santa Cruz de Tenerife in Spain. Thank God for my native Spanish speaking that I was able to pronounce all of that. Felix, is wonderful to have you on the podcast. We're really always very, very proud of Felix for all of the contributions he continues to make to gynecologic oncology. Also, he was a former fellow of the journal, so we're really excited to have this discussion. The reason for the podcast is the discussion on an article titled Sentinel Seneca Risk Factors for Unsuccessful Bilateral Sentinel Lymph Node Mapping in Endometrial Cancer. Félix Boria, it's great to see you. And again, welcome back to the podcast.
Thank you, Pedro, for inviting me here. It's always a pleasure to share a podcast with you. I would also want to thank all the Seneca study collaborators and also to my good friend Kike Chacon and my mentor, Dr. Luis Chiva. Without them, it would have been impossible to do all these studies.
Yes, absolutely. I completely agree with you. Congratulations to all of the co-authors of this study. So we're going to talk a little bit about that collaboration as well. But I wanted to start by discussing as to why did you consider this was a study that would add value to what we already know about sentinel lymph node mapping?
Well, sentinel lymph node mapping represents a relatively recent technique and has not yet achieved global standardization. Considerable heterogeneity exists internationally with respect to both the injection methodology and the localization process of the sentinel lymph node. So if you review the literature concerning bilateral lymph node mapping, reveals substantial variability and divergent outcomes. So when we designed the Seneca database, we incorporated all these previously identified as variables associated with successful lymph node mapping in order to evaluate their potential impact on the final diagnostic result.
Now, Felix, you mentioned the Seneca database. Can you tell us what's the Seneca database? And of course, obviously, we had Kike Chacon in the past on the podcast as well. But for those who may not be familiar with it, tell us about it. Tell us about the methodology of the study and what were your inclusion criteria for this study?
So the Seneca database is a retrospective multicentric European registry that was born from the Seneca study. The Seneca study collects data from 2,258 women with stage 1 and 2 endometrial cancer operated across 66 centers in 16 countries. All patients underwent surgery with sentinel lymph node assessment following ESGO guidelines between January 2021 and December 2022. All of them had molecular analysis performed. And for our study, patients were considered eligible if they were 18 years old or older. They had a histological confirmation of endometrial cancer, a preoperative FIV stage 1 or 2, without any evidence of local or distant disease. And in addition, a detailed sentinel lymph node study protocol has to be accredited either by ultrastaging or by OSNA.
And can you tell us a little bit about the primary and the secondary objectives of the study?
As the main objective of our study, we want to assess the risk factors associated with the failure of lymph node mapping in a large cohort of early endometrial cancer patients. As secondary objective, we want to evaluate the impact of avoiding bilateral pelvic and para-aortic lymphadenectomy, and also we want to describe the current trends in sentinel lymph node technique in endometrial cancer.
Excellent. So we do have lots of questions about the results and related topics as well. So let's get actually to the results of the study. What are some of the things you want to highlight? As you mentioned, very large study, 2,139 patients. Tell us about the results.
So among all these 2,139 patients, the bilateral lymph node detection rate was 82%, 2.7%, and the unilateral detection rate was 97.3%. So good numbers there. And our multivariate analysis revealed considerable heterogeneity among the applied techniques. However, we find 5 independent risk factors that were associated with unsuccessful bilateral sentinel lymph node mapping: high-grade histology, deep myometrial invasion, open surgical approach, low surgical volumes, defined as less than 20 cases per surgeon per year, and the use of a non-indocyanine green tracers, being these 2 less variable, the most strong predictors of unsuccessful bilateral lymph node mapping. Also, the addition of bilateral pelvic lymphadenectomy and or paraortic lymphadenectomy resulted in an increased rate of intraoperative and postoperative complications. Interestingly, we saw no difference in bilateral mapping regarding the injection technique. So we think that all our efforts should be made to perform this technique with ICG by minimal invasive surgery, and importantly, supervised or done by an experienced surgeon with at least 20 endometrial cancer cases per year.
Excellent. So now let's dive into the questions. As you know, being a former fellow, the fellows support the journal and the podcast by providing their questions to your article. And this first one comes from Elise Yates right here, actually, at Houston Methodist. She's asking, your study identified 5 key risk factors associated with unsuccessful bilateral mapping. What are the biologic rationales for each of these?
Yeah, very important question. So we found 3 modifiable factors and 2 non-modifiable factors. With regard to non-modifiable factors, high-grade histology and tumor with deep myometrial invasion may significantly disrupt lymphovascular architecture, resulting in obstructed or altered lymphatic drainage pathways, and thereby reducing the predictability of sentinel lymph node uptake. Furthermore, previous studies have identified lymph node enlargement or nodal positivity as potential contributors to mapping failure. It may be hypothesized that high-risk tumors are associated with an increased likelihood of nodal metastasis and a concomitant reduction in sentinel lymph node detection rates. Regarding the 3 modifiable factors, the open surgical approach may alter the anatomical tissue and present technical challenges when utilizing indocyanine green for sentinel lymph node mapping, specifically the requirement to operate with an open camera system, the switch off to the ambient lighting, and the resulting suboptimal visualization can hinder accurate identification of lymphatic pathways. ICG has shown in several studies superior tissue penetration and fluorescence properties compared to blue dye or radiocolloid, enhancing sentinel lymph node visibility. And the rate of bilateral detection improves when the surgery is performed or supervised by a surgeon with more than 20 cases per year. And this threshold was established by the ESGO in their quality indicators. And while this benchmark might seem arbitrary, it highlights the importance of surgical volume in endometrial cancer, as demonstrated in the existing literature, and underlies the importance of the learning curve for sentinel lymph node biopsy in endometrial cancer.
Excellent. So thank you for outlining the modifiable versus non-modifiable factors. And this next question pertains to histology and invasion. Julia Gellison from the University of Wisconsin-Madison, she's asking, are there any characteristics of this population that you think may account for the findings that high-grade histology and more than 50% invasion were associated with unsuccessful mapping, when other studies have shown that sentinel lymph node mapping to be successful, regardless of the histology or the myometrial invasion?
You know, this is a really tough one, and I can't think of any specific characteristics. But what I think we have to keep in mind is that high-risk tumor may have lower rates of detection. So pelvic lymphadenectomy must be done in these cases, or we have to be aware that we may have to do a pelvic lymphadenectomy in these cases if diffusion is not observed in any of the sites.
Yeah, so an area for further discussions in exploring. Another question from Julia. She's asking, is there any data to suggest that lower rates of successful mapping with open procedures are associated with lower surgeon volume for endometrial cancer compared to MIS?
Unfortunately, our study was not designed to look at this specific question, but my guess is that as both variables are independent in the multivariate analysis, my answer would be no. No, there is no relation between those two variables.
Okay. Next comes a question from Lucerne Cantonal Hospital, Christian Brown. He's asking, did your data set allow you to explore the main indications or decision-making factors behind the choice of open surgery in this study?
Yeah, that's an interesting question, but no, unfortunately, the Seneca database did not systematically collect the details of why the indications for open surgery.
Yes, as often is the case for retrospective studies.
Yeah.
Another question from Christian. He's asking, lymphovascular space invasion was not included among the investigative factors. Could you elaborate on the rationale behind excluding it from your analysis? Was LVSI data collected in the Seneca database?
Yeah, LBSI was collected, and I have to admit that I do take a look at the LBSI as many other factors, and LBSI was not associated with bilateral detection at least in univariate analysis, but we also didn't want to include it in the paper as it is often a postoperative histological finding. So we are not going to know it intraoperatively when we are doing sentinel lymph node mapping. So we think that it limits its utility as a predictor of mapping success.
Okay. Now let's get on to techniques. And Stephanie Gill from the University of Toronto, she's asking, was there any standard for the depth used to define superficial and deep injection technique? For example, in the Centaur study, the definition of their protocol was deep as 10 millimeters and superficial as 1 to 2 millimeters.
So the Seneca protocol allowed for variation between centers, reflecting real world practice, but we did include exactly that definition of 10 millimeters and 1, 2, or submucosal for superficial. And most participating centers use a combination of both superficial and deep, but the depth was not precisely recorded in millimeters in our study.
Okay. This next question again comes from Stephanie Gill, and she's asking, given the various volumes of tracers that are used, 1 cc's, 2 cc's, and 4 cc's, was there a way to track how much of the volume was injected at each location, or deep or superficial in the cervix? I wonder if you hit a threshold at 3 cc's and the technique is less successful.
So injection volume in our study was categorized into groups, 1 cc, 2 cc, 4 cc, or other, but site-specific volume distribution was not documented. We assume that volume of the tracer is equally distributed between injection sites. And generally, in all our questions, we divided the injection technique between 3 main techniques: the one using FARS study, the one using film study, and the one using Centaur study. So
yeah, and I think it's also just to add to that question as a comment, oftentimes we speak of 1 millimeter, 2 millimeters, 10 millimeters of depth. Are we really truly measuring exactly that there's this injection was 7 millimeters rather than at 8 millimeters? So
completely
I think it's like obviously a rough estimate at best. Now, getting on to the next question. This one is from Manel Montesinos Albert in Valencia, in Spain. And he's asking, did you evaluate whether using different concentrations of ICG impacted the success rate of sentinel lymph node mapping? You think standardizing or optimizing the tracer dose can lead to more consistent results?
So as I stated before, we analyzed 3 different concentrations of ICG, 0.5, 1.25, and 2.5 milligrams milliliter, but no difference in bilateral detection were observed between the different concentrations. So standardizing the dose globally is always a good idea, but based on our study, all three concentrations seems to work properly.
Okay. Now, turning to Thomas Bartel from the Medical University in Vienna, he's asking, the study highlighted the significant impact of surgeon volume, with surgeons performing fewer than 20 cases per year having a higher rate of failure. Could you discuss the implications of this finding for patient care and training?
Yeah, for sure. I mean, I think this finding has critical implications because it suggests what we already know, that sentinel lymph node mapping have a learning curve that we have to achieve to get good results. It supports the centralization of care or credentially based on volume, and emphasize the need of a standardized surgical training for sentinel lymph node mapping.
Now, let's talk a little bit about who actually performed the dye injection. And this question comes from Clara Santia at Houston Methodist. And she's asking, one particular detail that is of interest is who actually injected, the attending, the fellow, the resident. Did you analyze whether this impacted the success or failure of the mapping?
Yeah, we did. Interestingly, it doesn't affect the bilateral detection rate. We found no difference. So many times you see a lot of surgeons doing, no, I inject this in the two hours and I'll leave it there 15 seconds, and that way you're going to take the best results. But what we see is that you can have a fellow or a resident injecting your ICG and you are not going to have any difference. I mean, I think the important thing is that the procedure is supervised by an experienced surgeon, and especially the intraoperative part, I guess, the procedure of the sentinel lymph node mapping, not just the injection,
Yeah, I think residents and fellows are going to be very happy with your answer on that question.
Yeah.
So now this, turning to Matteo Marchetti at the University of Padua in Italy, are there techniques that surgeons commonly use, but in your data turned out to not really be very helpful? And certainly, obviously, it may be challenging to actually gather this from retrospective data collection, but he's asking specifically about re-injection or dissection of the presacral area. What are your thoughts on these techniques, and do you use them in your practice?
Yeah, very interesting. And both re-injection and dissection of the presacral space, looking for the lower part of the cervical pathway, showed higher rates of detection in the univariate analysis. However, both became non-significant when included in the multivariate analysis. I think first we have to acknowledge that if there are a lot of heterogeneity in the techniques, I mean, one center used this re-injection, but then injects in 3 and 9 and only superficial, another, that could alter the result in the multivariate analysis. And also, it is important to acknowledge, as this is a retrospective study, we analyze these variables only if the center routinely perform this in case of no diffusion, and we didn't analyze specifically those cases where no diffusion occurred, and then we re-inject or we look for the presacral area, and we didn't analyze that specific factor. I do use them when no mapping is observed. I have good experience with the presacral space, not so good experience with re-injection. I don't know, what are your thoughts on these two techniques, Pedro?
Yeah, actually, my personal approach is that I always place the camera first and then inject, and then I look to see that there is bilateral detection with the ICG detection. And if I note that there's one side that doesn't pick up the ICG, then I re-inject on that side, but all on the direct visualization. So this is even without dissecting the retroperitoneum. This is actually just looking through the peritoneum. So of course, through that technique, then the detection rate often is much higher because you're actually doing it sort of like live injecting and detecting it with a camera. So, but yeah, I mean, I agree. I don't know that that there is data in the literature to specifically look at this technique. Now, Thomas Bartle from the University of Vienna, he's asking about BMI. And of course, obviously, as you know, in the literature, usually what we know is that patients with a high BMI are more difficult to find sentinel lymph nodes. So he's asking, your study did not find an association between BMI and failed bilateral mapping, which contradicts some previous research. Could you discuss this finding and potential reasons for this discrepancy, including the limitation of available BMI data?
Yeah, this is a question that I have asked myself a lot of times, and this was a somewhat unexpected finding for us. There are some previous studies that have often linked obesity with reduced mapping success, but we have to say that there are also other studies that didn't. In our study, we analyzed BMI as a continuous variable, as a dichotomic variable, and we found no difference. We even built a ROC curve to find the best cutoff point, and we couldn't find one. So BMI in our database was neither close to be associated with bilateral detection. However, we have to acknowledge that we only had data of BMI in 30% of our patients. That is quite strange, but I mean, it was not a mandatory outcome in our database, and I guess some people just didn't feel it. And if we could go back, probably it would be a mandatory one. But, this is the retrospective data. This happened when you do retrospective studies. However, with this 30% of our cohort represents 600 patients, which I think it remains to be an important number of patients to draw conclusion from them.
Yeah. Kira Fisher from University Hospital Heidelberg brings up the point of low middle income countries and how this topic impacts that practice. And she asks, the authors state, using a tracer other than ICG increases the risk of unsuccessful lymph node mapping, hypothesizing that this is mainly the case in low income and low resource hospitals and countries. How do you think other factors might have biased the findings, such as lower surgical experience, unavailability of robotic-assisted surgery, etc.?
Well, it may have. I mean, the use of a different tracer than ICG in our cohort represents only the 3% of our patients. So, I mean, our study is almost a ICG study. However, I think it was the strongest prediction for non-bilateral detection. So I think that ICG really matters in this case, not only the resources and the low middle income countries.
Yeah, and I think certainly, obviously, it goes to the surgeon experience, and then to continue advocating for surgeons who are starting their learning curve to still do a lymphadenectomy in the indicated cases, to look at their false negative rates as well. So now, Felix, just a few more questions. I do want to ask you, what are the limitations of this study?
Well, several limitations should be acknowledged, and the main one is, of course, its retrospective design, as we were talking about it before. And I think it's also important to address the huge heterogeneity that exists among centers in the practice doing sentinel lymph node mapping, that complicates the possibility of isolating specific risk factors, because if you classify all the different techniques that are used in our study, you may have, 150 different techniques, if you combine all the different things that people are doing differently from one place to another. So it's really difficult to know if that is going better because of the superficial injection or because of the ICG, and that's a bias for sure. We also have to acknowledge the missing data on BMI, and we also didn't have any centralized surgical or pathological review, which potentially introduced inter-observability to node positivity. However, the large multi-center datasets enhance the generalizability, and reflects real-world sentinel lymph node practice more accurately than tightly controlled prospective trials.
Yeah. So perfect segue to my next question, last two questions. Manuel Montesinos Albert, he's asking, your findings highlight significant clinical and procedural variability across centers. What steps would you suggest to develop a more unified, evidence-based guideline or pathways to standardize SLN mapping in endometrial cancer?
So to minimize clinical and procedural heterogeneity, I think it's key to develop unified guidelines endorsed by Major Society, ESGO, NCCN, IJGC, with specific standards on trace type, volume, injection site, and depth. There should be also mandatory SLN training programs and minimal surgical volume requirements for centers offering sentinel.
No, Felix,
sorry.
Go ahead. I'm sorry.
Yeah. We should implement a checklist of intraoperative algorithms, and we should regularly audit our data always to check if we are doing things properly.
Excellent. Now, as a last question, this comes from Matteo Marchetti. He's asking, what is your institutional standard for sentinel lymph node mapping in your practice? And can you share with us when you inject, before or after entry, how much you inject? Do you change anything if there is obesity? And what do you do in the setting of open surgery?
So we don't change anything in obesity or open approach. We inject before the entry. We use indocyanine green and at a concentration of 2.5 milligrams milliliter. We use 1 milliliter insulin syringe, and we inject the 4 cc's in total, 1 cc submucosal and 1 cc deeply at both 3 and 9 o'clock of the cervix. However, regarding a study, it seems that the injection technique is not the most important thing for bilateral detection in endometrial cancer. We have to do it minimal invasive, we have to do it with ACG, and we have to select some surgeons in our hospital that get the best learning curve and that they have at least 20 sentinel lymph node procedures per year. I think that's the most important thing to achieve rather than the injection technique.
Well, Felix, thank you so much. This has been very informative. Really enjoyed speaking with you, discussing this topic. And, again, obviously, thank you for exploring what are some of the potential indicators for unsuccessful mapping, and what are the strategies that we can use to ideally reduce the unsuccessful mapping rate. So really very much appreciate your time. Enjoyed the discussion. Look forward to visiting you in the Canary Islands at some time soon. And once again, thank you for submitting your manuscript to the journal. Congratulations to all of the co-authors, and really very, very proud of you and all of the continued contributions you make to the field of gynecologic oncology. Thank you.
Thank you, Pedro.